certain issues as it pertains to COVID-19 and vaccines. So it was just, it was a good experience where I had to be able to back up what I believed in and share that with everyone. And I think that I was able to open some minds who were willing to speak about the vaccine, and also being engaged in getting into the community outreach events. It was just a very impactful summer for me and definitely thankful to be a part of the program.
Thank you so much for sharing those perspectives, Ms. Reed, and thank you for your leadership. We say at Morehouse, we are developing emerging learners who are also leaders. And so even in the process, you're demonstrating how your lived experience motivated you to engage with HealthWorks and do something. So next, we'd like to turn it over to Ms. Lori Kenya, who is also with HealthWorks. Please share your lived experience. The floor is yours. Ms. Kenya, we cannot yet hear you. Let's make sure you're not on mute. So we're going to come back to Ms. Kenya. We know her perspectives are so very important to our discussion and our dialogue. So we're going to move on to Mr. James Perkins, if he is on, so he can share his perspective from where he leads and learns.
Thank you. Can you hear me?
Yes.
Oh, okay. Well, my experience, I am a mechanical contractor here in Tennessee, and I install, sell, and service heating systems and air conditioning systems. And a friend of mine asked me if I had gotten COVID after receiving the second vaccination. And I answered yes, and so he asked me if I participate on this call. Basically, I'm in and out of a lot of people's homes, a lot of public buildings, a lot of supply houses where I can go and purchase parts. So I come in contact with a lot of people, and I began to feel kind of lethargic, and I was walking real slow. And somebody who had COVID told me that I need to go get tested because those were the same symptoms he had. So I went to my Harry through their line where you get tested, and so a few days after taking the test, I got a text message or email saying that I had COVID and the quarantine for X number of days. So I did, and then I went and to the Metro Health Department. Back in March, I went and got my first shot, and then 2 weeks later, I got my second shot, and then I started working again, going into homes and businesses and so forth, and then I started experiencing the same feelings again. So I went to Matthew Walker and got tested, and it came up negative, but I was told to go to the health department in a couple of days and get a second test because I had all the symptoms. So I went, got the second test, and sure enough, it came back positive. But I'd already had two vaccinations, so I followed instructions to quarantine. And then my wife and all my family left one night. One day going to Memphis, and when I was sitting down watching TV, I couldn't breathe. All of a sudden, my chest started hurting. I couldn't breathe. I stood up. I walked around the couch a few times, and I opened my mouth and was trying to breathe. And all I could think about was what people were saying about the COVID was like pneumonia and so forth, and I was beating my chest, and after a few seconds, I started breathing again. So so at that, and I felt a rumble inside of my chest. So I felt like, I said, man, that vaccine must be working. So after that, I was a little more careful in what I did. I got not vaccine. I have a sanitizer in my truck. My wife bought a bunch of masks, and I had rubber gloves or whatever. But I began to be more careful. But the way I got the second case of COVID was, I went into a house where someone had COVID, and I had my mask on, but I was talking to the owner at the thermostat, and I pulled the mask away from my mouth, and I think that's what exposed it. But I sensed, I went back to the health department after they said I was okay, and basically the message I received was, if I couldn't breathe, to go to the emergency room. And of course, I started laughing because I said, man, when I couldn't breathe, I couldn't drive either. So, and I was by myself. But I was just glad that the city, the Nashville Health Department, I was glad for Harry, and glad for Matthew Walker, and just to treat me. And since then I've watched like what I do, stay in contact, and so I'm the only negative experience I've had is that after having COVID, my taste buds changed. I used to like eggs and cheese, and I don't care for I don't care for eggs and cheese anymore. And I lost weight, but I've started to gain it back. And then I'm moving a lot faster than I used to move, so I'm not as lethargic, or I don't have this energy. I do have energy now, and I guess I was in one of those groups where they said that we were vulnerable because I'm 74 and I had high blood pressure. So, but anyway, having taken the vaccine, I'm glad I did, because I think in my own mind, I think that they were working when I got the second case. And that's my story.
Mr. Perkins, we so appreciate your vulnerability and you sharing what your experience and path forward has been. Dr. Brown, I know we are going to be checking the chat for questions and comments that come through, and that we'll take at the end of this session. So all of you who are sharing your experiences and your perspectives, do hang tight, because there may be a question or comment coming your way. So next we have Ms. Barbara James, who is with HealthWorks, and she's the director of vaccine or vaccination work at our partner site in Nashville, Tennessee. Ms.
Good
James.
afternoon. I am Barbara James, the organizer of a grassroots organization called Vaccine for All. This is a group of volunteers that go into the hard to reach areas to encourage the citizens to get vaccinated. We also take information to encourage them to trust the science, trust what the health department is saying and what the doctors are saying. On March 13th, 2020, the local news reported that there was one case of COVID-19 in the Tennessee area. Almost 18 months later, Tennessee reported over 1 million cases and over 13,000 deaths. Of course, this number has increased significantly since I took this information. In a progressive country like this, these are alarming statistics. Even more alarming is the number may be underreported. Just think about it. Those who died at home, the homeless people who passed away, and people who didn't get any there were persons who didn't have any medical attention at all. So I am sure those numbers are different. Excuse me. A large percentage of the infections and deaths also affected our community. When COVID-19 vaccines became available, my thought was we'll all get vaccinated and our lives could return to some level of normalcy. Because I had the tools and skills and the computers and time, it wasn't difficult for me to schedule my vaccination and go and get the shot when my age group became available. However, for many, navigating through those cumbersome web pages, many not having access to computers, some not having transportation, or either not having time off work, this became a barrier. Vaccine for All was organized to help overcome this barrier and challenges of getting vaccine. After setting up clinics and meeting with members of the community, we soon discovered that skills, tools, time, and having readily access to the vaccine was only a minor challenge. The major challenge was misinformation and the lack of information. This disease is ravaging our community, but the misinformation and distrust continue to perpetuate this health pandemic because it does not allow us to make an informed decision about our health. Society asks, why does this disease affect the marginalized citizens, the Black and Brown communities in such high rates? As I interact with the community, there are many reasons, such as access to life-saving treatments, misinformation, and economics. Black and Brown citizens were essential employees working in grocery stores, hospitals, nursing homes, and restaurants. They were easily exposed. And as Mr. Perkins said, he was essential, he worked in homes. Many of us did not have full-time jobs with paid leave or the job that allowed you to work from home. Exposure was great. And in many cases, individuals would ignore exposure and continue to work. They would say, if I didn't work, I didn't eat, or I couldn't pay my rent. I cannot afford to take 14 days off without a paycheck. So yes, it did affect our community, but we are working hard to overcome those challenges. Our objectives are set up vaccine clinics within the community to eliminate barriers such as computer access, transportation, and scheduling. Partner with other organizations to provide information to dispel COVID myths. We encourage participation by hosting special events, things that people will come to. Bingo for senior citizens at senior residence, special food drives, programs in housing community, how you can get your rent paid, other things, voter registration, festivals, and cookouts. We feel if we can get you out, we can tell you the story and we can get our message out. So that's what Vaccine for All does. Thank you for the opportunity.
Thank you so much. You've hit so many points that really speak to knowing the community, pivoting and being responsive. So thank you so much for that, Ms. James. Dr. Brown, looks like we might have time for one question.
Absolutely. So we do have one question that came up for Mr. Perkins, and if anyone else wants to answer, it just says, what messages would you give to others who are slow to get vaccines? And is there anything that would have encouraged you to get vaccinated before getting diagnosed with COVID-19?
Well, you know, I meet with a bunch of guys sometime for breakfast, and they talk, and some of them, they want to have the vaccine. So I just, this is not what you want to hear, but I simply tell them, like, you just go ahead on and die if you don't want to take the vaccine. But I tell them that my feeling is that had I not taken the vaccine, especially the second shot, that I wouldn't be here, because I couldn't breathe, you know, and I don't know how many people have experienced not being able to take a breath, but when your chest is burning and you can't get air in, you got your mouth open, and you know that if you don't get any oxygen, your organ's going to start to die. It just makes sense to listen to the science and make yourself available to do what they tell you need to do. And I'm thankful that I paid attention. I did what I was asked to do. And now I'm still here with my wife and my kids and my grandkids, and I'm working. So I just think it's stupid not to take advantage of the messages of the science that's available. And I tell people, I say, they always said that they didn't want to take the vaccine because they didn't know what was in it. And my answer was, you drink Coca-Cola and you don't know what's in it. So basically, you know, it doesn't make sense, your statement. So that's why I would tell them, you just need to go ahead on and die. But I know you don't want to, but that's just my perspective.
Thank you so much, Mr. Perkins, and others who were a part of that first bit on the lived experience. Please do include your comments and reflections in the chat. We have so many other experts who we're going to hear from. So we'll make sure that we navigate both the chat as well as other feedback that comes through along the way. Thank you so much, Dr. Brown.
You're
So
welcome.
Yes, so
And
now here.
Dr. Matthew Suarez unmuted, so I just want to recognize her.
Yes, thank you so much. And I just wanted to do a shout out both to Mrs. James, who is in that community nonstop, who has really spearheaded the saving of, and Mr. Perkins, whom I have had the honor of having dinner with. And he's plain talking, and that's what we need, to be plain talking, so that we reach the groups that we need to reach without talking about it in highfalutin terms that nobody understands, but think, what did he really say? So thank you. Thank you so much, Dr. Brown.
And thank you so much, Dr. Matthew Suarez, for your comments and reflections. It takes all of us, and we certainly are thankful to them for their lived experiences. So we're going to pivot now to the topic of strategic planning. And so our first speaker will be Ms. Holmes-Jones out of Nashville, Tennessee. Please take the floor and share your perspectives. Ms. Holmes-Jones, the floor is yours, and be sure to unmute. Okay, we'll give her some time to jump back on. And as folks, as we all know, we have to pivot. And of course, we'll make sure we have people to get back in once they get on. So we will move to Brittany Taylor, who is the project director for Georgia SEAL, and we'll be on the lookout for you, Ms. Holmes-Jones, so we can catch back up and have you share your perspectives on strategic marketing. Brittany?
Good afternoon, everyone. Just want to share with you all what we at Georgia SEAL have done as a collaborator and partner with the HealthWorks Consortium. Thank you. So as a part of our work for our strategic marketing and communications approach, we decided to launch HealthWorks Community Small Grants as a means of engaging small businesses and community-based and community-serving organizations across the state of Georgia. And so we released a call for applications regarding the small grants. We ensured with these small grants that a main component of them were to, one, generate COVID-19 education, testing, vaccination materials, as in flyers and handouts that would educate the community about long COVID, as well as build confidence around the COVID-19 vaccinations and just build confidence and trust in general around COVID-19. Another facet of that marketing and communication that we did with these small grants was ensuring that our grantees were also disseminating, sharing information that was generated from the HealthWorks Consortium and partners. And so they were asked to disseminate these at their events, as well as on their social media platforms, in addition to any emails or any other types of communication that they would be sending out regarding the HealthWorks Consortium. And so after releasing our grants, we did receive we did award, I should say, 4 grantees. 3 around the Metro Atlanta area, and then we have 1 down in the Albany area, all within Georgia. And so as you can see, the deliverables are here on the screen, but they were also tasked with sponsoring COVID-19 forums hosting COVID-19 forums that were co-sponsored by Georgia SEAL and HealthWorks. And so that also meant ensuring that they branded all of these materials with the HealthWorks logo, as well as the Georgia SEAL logo, and communicating their events. So they also hosted COVID-19 education events in addition to the vaccination events, and they actively participated on our Georgia SEAL Community Coalition board. Next slide, please. Additionally, we launched the small grants in June.
If you can't get her, then you speak for her, okay?
I'm sorry, could everyone mute
Think
themselves? We also launched the HealthWorks CCB Engagement Awards. And so with this opportunity, we decided to use our Georgia SEAL Community Coalition Board. And we offered this opportunity solely to our Community Coalition Board members, which are comprised of about 30 different organizations across the state, which means they're all their own organizations and had their own populations and target audiences of reach. We also charged them with the same thing of creating COVID-19 education, testing, vaccination, and mitigation materials, and also disseminating those materials in addition to the HealthWorks Consortium happening events and materials. They also were in charge of, with hosting one COVID-19 vaccination event and also an education event. Some of them have gone above and beyond and have been hosting several, but we again awarded 5 of these, and 4 of the 5 are around the Metro Atlanta area, but we did hit the Macon, so the Middle Georgia area, with a Fellowship Missionary Baptist Convention. And then to bolster our strategic marketing and communication efforts, we awarded a community partnership grant to the Andrew J. Young Foundation. And as part of this grant, they were to develop 3 public service announcements on COVID-19. And so the first one was launched in August, and in keeping with August and September returning to school, we had them focus on returning to school safely, and that was the children, the parents, as well as the staff. We also released a second PSA on long COVID and the importance of knowing what long COVID is, and also how to protect yourself, i.e. taking the vaccination, staying hydrated, and things of that nature, and knowing when to get help. And they will be releasing another public service announcement upcoming, and it will be on the basis of protecting yourself, your loved ones, in light of the holidays, with everyone going back more so indoors, and ensuring they are protected. Next slide, please. And then here is an example of some of the materials that were generated for HealthWorks. So you'll see where our Shifa Inca grantee created this handout speaking to the journey of COVID-19 vaccines and how they were created, and also encouraging vaccination, not hesitation. Then you'll see in the center where we created a handout information about vaccinating our kids. We know that that is a new point of focus, and so we want to ensure we're providing accurate and helpful information around that. And then in addition to the informational handouts, our grantees also created flyers. And so you'll see some of the flyers here, one from the 100 Black Men. Also, our Hispanic Health Coalition grantee created their flyers in both Spanish and English. So we're ensuring that we reach that Latinx population in addition to the English speaking and African American population. And you'll also see they did vaccinations in conjunction with health fairs, family fun days, things of that nature. And as a part of the town hall and forum deliverable requirement, you will see that we have our Fellowship Missionary Baptist Church engagement awardee hosting their own long COVID town hall this evening at 6:00 p.m. And so this flyer was created by the Black Cross, which is another awardee. So they will be assisting in producing that and communicating and spreading the word and more information about COVID-19 and long COVID and its effects on the African American community. So that is the bulk of what we have done at Georgia SEAL. We always ensure that we post all of this information on our social media platforms, and we ensure that the information that's created for HealthWorks and Georgia SEAL are disseminated out in our weekly events and resources releases that we share with our larger Georgia SEAL network. In addition, we also have the Black Cross post events and flyers and upcoming information around long COVID and COVID-19 pertaining to the HealthWorks Consortium on their social media platforms, and they also included in their weekly newsletters as well. So that is what Georgia SEAL and our HealthWorks grantees have done around strategic marketing and communication to boost confidence about the COVID-19 vaccine.
Thank you so much for that robust presentation. We are always excited to hear about the amazing things that are happening in the community. I just want to do a quick check-in to see if we have Moncherie Holmes-Jones on yet.
So, hey, Dr. Catherine, she had a little bit of emergency, so I'm just stepping in for her conversation.
So very good. We're excited. So we're doing a moderator pivot is happening too, and we're just going to keep being a pivot and be resilient. But I will tell you what, everyone, that is the word that we learned throughout this pandemic, resilience. And so for those of you all who are just logging in, I'm Dr. Catherine Y. Brown with HealthWorks Meharry. So Joshua, please, at this time, welcome.
Good afternoon to everyone. Again, unfortunately, Moncherie is unable to join us today. I'm Joshua Oganyemi, worked alongside her over the last year and a half with T and SEAL, really bringing amplification to the messaging around COVID-19 and awareness. We did that in a number of ways, and one through our hyperlocal events, through social media campaigns, and I don't guess I'll have the opportunity to share that with you, but visibly, but I will attempt to speak through some of those points. But what we learned, as Dr. Catherine mentioned just a moment ago, is that resiliency and that ability to pivot. So throughout our campaigns, we found it necessary on several occasions to stay flexible in our messaging. That was key to how we were able to stay relevant during COVID. As we know, things changed very, very rapidly. We were learning on the fly and while trying to educate on the fly. So, it was mask or no mask, or it was, booster or no booster, or certain or not booster, no booster, or when to get the vaccines and all those different things. So we had to play around with a lot of different messaging. At one point, we talked about how I'm scared for you. We encourage the public to smile because those are just a few different ways that we work through it, up to our current messaging campaign, which is Live Well Vaccinated. So everything that we do, we're pushing that messaging forward, that not just in terms of COVID or in terms of vaccination, but creating a larger conversation around living well. So that's reflected in the events that we promote, the local events, that's reflected in the social media content that we're able to produce. So whether it's for breastfeeding or whether it's cancer related, mental health related, all these things tie into the fact or the messaging of living well. So we tag that Live Well Vaccinated. A part of our, just to give you a quick rundown, I'm not even certain how much time I have, but just want to give you an idea of we call amplification. So we bring that message to the public. We do that in a number of ways. We do that through our brand strategy, through social media content, as I mentioned, community relations. So that's getting out to not only T and Seal sponsored events, but tapping into what the community already has going on. So we were very strategic in infiltrating and positioning ourselves where there already was an audience. And we were able to take advantage of large events, not only here in Nashville, like the African American Street Festival, which saw thousands of people over the weekend. So we're able to, like I said, infiltrate those types of events as well. In terms of also in terms of community relations and these events, we are hosting wellness pop-ups all across Tennessee. So that is, we're partnering with organizations and businesses to say, hey, let's come in. It's free of charge. We would love to come in and inform your employees, your staff, inform your congregation what COVID is, what the ramifications are, what long COVID is. A lot of folks are thinking or have the mindset that COVID is over. And so we're here to help them understand, nope, it's still very present. We're still learning a whole lot from this entire COVID experience, not just up to the vaccination, but even beyond that. So we talked about in terms of long COVID and et cetera, the long-term effects of COVID on the physical and mental health.
Thank you so much, Joshua. We are going to pivot to our next segment. All that you described is so very important. So we want to keep the chat moving, and we're going to have a chance for people to share their questions that we'll make sure to get to. So please do hang on. I got the cue that we need to try and stay on time. This information is so rich, it's just hard to contain it all. So please stick around and keep your comments and questions coming through in the chat. This next segment is on engagement, recruitment, training, and deployment strategies. And we actually have two folks representing Atlanta and Tennessee, Nashville, to talk about these strategies. Gail McCrae is a community health educator at Morehouse School of Medicine. Gail, please take the floor and share your perspectives.
Good afternoon, everybody. Thank you, Tavia. Could I have the first slide? I'd like to talk about, it's such a great effort, but, it requires a lot of effort, a lot of different people. If you consider that Morehouse School of Medicine was going to recruit 100, I can take the next slide, please, 100 what we call health outreach workers to do this work, as did Tennessee. So 100 people in each place, 9-month effort, just going back and thinking about that. And then our business partner, Ashland, was to recruit, and they over-recruited 100 businesses. And so we had to get folks recruited, but what kind of people would come to us and say, I want to work temporary, part-time, and this job is going to end very soon. So you go into it knowing that it's not a long-term job. We had to have people who were comfortable using the computer because a lot of the communication, a lot of the data gathering was going to require that they use computers. So, it couldn't be people who were just passionate about their community and wanting to save the community. They had to be comfortable. They had to be computer literate. And they had to be quick learners. The training was intense and quick. And they also had to pass background checks. We talk about consistently the message and messengers. And so we really did have to look at who the people were who were being hired, that they had a passion for their community, whatever community meant, whether it was their church community or family or school or geographic area. They had to have a passion for community and for health and health promotion. There were events across geographic areas. And these, what we call on our end, health outreach workers, had to be able to quickly get the trust and respect of the public as they approach them. We call them health outreach workers on our end because community health workers go through a lot of training, and it takes months and months and months, as you might imagine, that a community health worker who's going to be woven into the fabric of healthcare. That person is going to be trained for more than 200 hours and have to do shadowing and just as any other health professional. But the health outreach workers were trained on about maybe 6 of the modules of the 20 modules from community health workers. And those we also leveraged, as you see there, partnerships with Georgia Seal, as you heard from Brittany, people who were already doing this work, join hands, build on what they're already doing, but expand and expound on that. So we were partnering with public health, and we looked at friends and retirees, people who might be able, once again, to do this work. That was a part of the recruitment. And we were able to recruit more than 100 health outreach workers. They were students. They were in health-related occupations, and that was interesting to me. Some of them decided they wanted to build on what they were already doing and use their knowledge and experience to join with HealthWorks and to help us with this project. There were retirees, and there was at least one husband and wife team, and then there was also a family that joined. The next slide, please. And so I just mentioned that our curriculum for community health workers was adapted for this program. It was compressed from the usual 20 modules. We included community assessment, had the health outreach workers actually conduct windshield surveys. So they got a feel for what it means to find out what's in the community that you want to serve. And so noting in their windshield survey where were opportunities for them to engage and interact with the public, where were grocery stores, where were the schools, where were the churches. So they did windshield surveys. They also were trained on motivational interviewing, ethical considerations. This is still health promotion, and we wanted people to be aware of the things that they needed to do and know about bioethics. We talked a lot about myths and facts and showed them where to find where the reliable resources are on myths and facts for COVID, where the resources are, so that they could find them themselves and they could share those with the public as they approach them. The training was conducted online. The initial training, the basic training that we wanted to promote, a little bit of, hiccups, and people weren't really getting the online training. And so we held a couple of late afternoon, evening training sessions so we could get everybody trained at once. We went through the modules one by one, got people's input, had them, do some of the exercises that they had to do. And so that was the basic training. And as Dr. Lazar mentioned earlier, we had 4 continuing education sessions each month, and to reinforce the messages that we shared in the initial training, but also to address any issues or concerns that they had in the field in the interim.
Gail?
Yes.
I am sorry to
Yes.
cut you short. We are
Got it.
running short on time. We want you to
Okay.
hold the rest of your comments and
Sure.
feedback as we try and get through the official segments and then come back to Q&A. So thank you
Wonderful.
so much. We're going to get right back to you. Please hold the rest of your comments. We'll have time to share them a little bit later. Dr. Chandra Wade, who's with Nashville, Tennessee, is going to share her perspectives on the same issue, and it'll be interesting to see how those issues compare and contrast. Dr. Wade? Dr. Wade, make sure you take yourself off of mute.
Sorry. Good afternoon, everyone. I am Dr. Chandra Wade. I am the business consultant for Meharry Medical College here in Memphis, Tennessee. And the first slide, please. The first slide. We did reach our goal of 100 community health workers here. And one of my jobs here in Memphis is to go out and find businesses or either organization who would like to host a COVID vaccination event. And some of the pros and cons that we found. Is my slide available?
Team, do let us know. Are we able to share Dr. Wade's slides? Dr. Wade, I don't know if you have them that you could share your screen.
I don't have them. Hold on.
Okay, let me see. I just got a note in here. All right, is there a way for Dr. Wade to share her screen? I think you can, Dr. Wade, if you're able to.
I don't have it on this computer.
Okay. Well, we regret this challenge. If you can talk through what you have, and we'll do our best to see if we can't share them, please.
One of the pros out during the community outreach was that most people were more engaged in getting a COVID vaccination. We have opportunity to speak to a lot of the members out in the community. And then we have some who were still against getting a vaccination. We have not, here in Memphis, we still have a high number of people who have not been vaccinated. So my goal is to continue to go out and do outreach to have them to get vaccinated.
Dr. Wade, it may be helpful for you to talk a little bit about how the 102 that we recruited, as well as the kind of training that we did, that we provided 3 levels of training. One was clinical training for survey interviewing. The third was motivational interviewing. And then we also overlaid that with community engagement and a certificate that came from the Baptist Health Science Center. In addition to that, we employed 20 of the community workers to work with us around getting the vaccines and the boosters into the system. Along with that, they also participated with us around survey taken around pregnant women with children who were coming to site. So I led you to those kinds of things. So you may want to just take a moment and talk a little bit about that and the work that you've done with the Community Health Center and with AHEC. Over.
Yes, we did recruit. Most of my recruitments came from the AHEC students here in Memphis, where they went out and did the shots for us, medical students and pharmacy students. We also recruited social workers. We had a lot of people who was already doing the community outreach, such as the health department and many other students who are already in the program. We did training every 3 months with our recruitments. They were able to get 3 certificates, and some are still getting other certificates through UT. And one of the other things that I went out and I did was did events with many of the organizations here in Memphis, where we set up with SHARRx and another one of our community partners, where we provide the vaccination and the booster shots for them.
Thank you so much, Dr. Wade. Really appreciate it.
You're welcome.
Indeed. Thank you so much, Dr. Wade, for your insights, and we regret not being able to share your slides. We need to give you an opportunity to answer this question that came through. What were any lessons learned in the process? Anything that comes to your mind as a lesson learned in the work that you described?
I think one of the lessons I learned that most people in Memphis are still scared of getting vaccinated, and just talking to them and sharing my story why I became vaccinated. And I tell people all the time, I have a 76-year-old mother here that I have to care for. And so if I get it, will she survive? So I had to make the choice myself to get vaccinated. And once I shared my story, then many of the others, they went and got their shots. Or they'll come and say, well, I'm going to get my shot. So that thing, just telling my story helped a lot.
Mm-hmm. The other lesson that we learned was that the individuals that we recruited as community health workers also had jobs. Yeah. And so having jobs were very difficult for them to sort of share themselves out in the community, as well as going to class to get this certificate. So one of the lessons we learned was that the program has to be flexible, it must pivot, and we must provide support, financial support. Mm-hmm. And that financial support has to include childcare, and it has to include transportation. And we have to create a pathway that takes us from being a community health workers, because we've done this before. Mm-hmm. We've done this before. So public health, social work, all the things that Dr. Wade talked about, pharmacy, nursing, all those different professions have to be pathways for community health workers. We can't just do community engagement anymore. If we want to sustain and begin to be ready for the next pandemic, and as we go through the endemic phase of this work, I think that the lessons that we see is very compelling, and to what Dr. Wade is doing, working across the state with the federally qualified health centers are another way, other ways to ensure that the community health worker will have a position and be a part of the primary care team. So I think those are the things that we've learned that are exciting, and the work that we're doing and what we see on the ground.
Thank you so very much. And folks, please do put your comments and tee up your questions as we move to our last two segments. I'm really pleased to introduce and give the mic to Harita Harper, who's a program manager with HealthWorks. Community engagement is so very important in the ways that community outreach workers are positioned as integral and irreplaceable parts of the equation as we think about all of the important stakeholders in the process of COVID recovery. Harita can tell it in very important and unique ways. Harita, the floor is yours.
Thank you so much, Dr. Akintobi. Again, my name is Harita Harper, and I was the interim community outreach worker program manager for the Innovative Learning Laboratories here at Morehouse School of Medicine. And I just want to give you guys a brief overview of what a community outreach worker is. The community outreach worker is somebody that supports, somebody that serves, somebody that organizes, somebody that educates, somebody that expands and mobilizes in their own community. This is a trusting relationship that the community outreach worker forms, and they become a liaison, they become a link between social services and the community to facilitate services and improve on the quality of cultural competence of services that they deliver. Next slide, please. So what was the goal for the community outreach worker? Well, again, it was those things that I just went over, is what they already do to engage, organize, and mobilize, to build COVID-19 vaccine confidence, to reduce health disparities and advance health equity, and to strengthen COVID-19 vaccine confidence through trusted, culturally appropriate information. And lastly, to increase access to vaccines and booster shots for a diverse and medically underserved population. So those were our goals. So how did we achieve that? Well, we actually hired 100 community outreach workers that we're really proud of. We trained community outreach workers through Canva courses to receive a certificate of completion. We also conducted live 3-hour online training sessions to enhance outreach communication. We also hosted live strategy sessions to promote peer-to-peer empowerment. We also collaborated with small business administrative ambassadors, and we also deployed community outreach workers in 6 public health districts. Next slide, please. So this is our results. We did way over 30 vaccines and outreach events. We also had weekly pediatric clinics, and that was hosted at Morehouse School of Medicine clinics that we have. We have two different clinics that was hosted at. We also collaborated with our small ambassadors. So each community outreach worker was paired with 2 small business ambassadors. We also had community health outreach workers in 18 counties throughout Georgia. And we also reached and were in 6 public health districts. We have 10 public health districts in Georgia, and we were in at least 6 of those public health districts. And I like this as the drum roll that we actually touched over 67,000 Georgians. And so that's why health works in Georgia. And that concludes my presentation. that completed mine, Dr. Akintobi and Dr. Brown.
Ms. Harper, thank you so much. I couldn't hear. I was having a little technical difficulty. You all, thanks for bearing with us. We see that there are some comments in the chat, and as they are coming through, let's go ahead and move us to discussion on using data for decision making. So we have Mr. Juan Carlos Gonzalez, who will talk a little bit about that. And specifically as it's related to the health equity tracker.
Hey everyone, thank you so much for your time. If you want to, I'll have control for the slides, correct?
Yes, you should be able to.
Okay. Okay, there we go. Thank you. And I could just click ahead. Okay. So thank you for that introduction. As you've heard, I'm the product manager for the Health Equity Tracker at the Satcher Health Leadership Institute. A lot of my time is really trying to understand the challenges and opportunities around health data, and specifically around defining an equitable data practice of how we could bridge the gap between data collection and reporting to meaningful use at the community level. So programs like the Vaccine Confidence Initiative, how can we best leverage data and technology to really be actionable for people in the community to support the programs that they're trying to get across. So we've been very fortunate to support the work being done by so many amazing organizations, advocacy groups, policy influencers, and really the goal for the Health Equity Tracker is to use data to advance health equity for all, wherever that may mean, whether it's through research, as I mentioned, community outreach, or through policy initiatives. So the question, and we really began with this, is how would a data platform that places health equity at its core, how would that look? How would that be different than a different dashboard? How would that guide the data that we present? And how would that lead to a different user experience? And we really wanted to develop a new set of visualizations that really highlight inequities, that disparities that are present in communities, despite maybe small populations or data challenges, that are really quick and easy to understand. And we wanted to take it a step further and not only show outcome data, but link the root drivers in the social and political determinants of health to those outcomes. So we felt it's not enough to show the data, but we need to try to take steps to explain why do these outcomes exist by different populations. So when we really wanted to start, is really it felt natural to start at the problems, and do a data landscape review. And we really partnered with our sponsors to really do a research study and look at the problems of data and what does that mean. And we probably, no surprise, there's a ton. So this slide is pretty big, but I'll fly through it. The first question is, what does equitable health data look like? When we try to define that, there's not a lot of literature into what is data equity, in terms of removing barriers to data, improving access to the data, making sure data is representative and things like that. There's not a lot of products out there that really take an equitable approach to the data. The second major problem that we learned is, how do we incentivize interoperability? And really what that means is sharing data. You can make an argument that really organizations are really incentivized not to share data because data could be monetized. So how do we encourage people to share their data, encourage communication between systems and organizations, so we have a more complete picture in terms of data landscape? The difference in stakeholders' needs. This is another major challenge. Someone that's in a community has different needs with the data than maybe a physician or maybe a researcher. So when we're trying to bring in all these diverse and interconnected topics into one website, we really need to speak directly to the different stakeholders and their needs, because we learned that, one size fits all approach really doesn't work. I mentioned this earlier, supporting meaningful use. Again, most dashboards present the data and stop there. We really want to set the groundwork into saying, here are why these conditions exist in the first place. So those could be acted upon and not just the data itself. Again, maybe not surprising, there is large inconsistency in terms of data collection and reporting. This is a major issue for us because I'll give you a quick example. If you're looking at race and ethnicity, Hispanic may be defined differently in one data set than it is on the other data set. So when you try to combine them on a single platform, it's really not truly the same definition. So the fact that there really isn't a best practice into here are the definitions in terms of data collected, here are the generally accepted definitions and how those findings should be reported, it really is a big problem in terms of trying to get them all in one place. Different definitions, I just mentioned that. Unconscious, and I'll fly through a couple of these. Unconscious bias, we understand there's institutional mistrust from different population groups that they don't know how their data may be used. They may not be willing to share their data. And then to further complicate, who owns the data? A lot of organizations, especially healthcare providers, it's not clear, is it patient-owned data or does the providers and the organizations own that data? So how do we overcome mistrust? And there's a big justification for credibility and establishing trust with the patients and the people offering their data so they understand how it's going to be used. Politicization of data. Again, we've launched the Health Equity Tracker to really try to be nonpartisan. We are about a year old, and at launch, we really just wanted to present the data. And again, not a lot of narrative around it. We're not trying to pick a side in terms of what are causing these conditions, but again, we understand that data could be used to leverage certain platforms, and that really is a big problem when you're trying to just appeal to a large audience to demonstrate, here's the data, the best data that we have available, and here how it could be used to benefit everyone. Systemic racism, we know is a big issue. Misrepresentation, again, especially for some populations, if they feel the data is not collected in a way that is representative of them in terms of demographics and who they are as people, that actually could be harmful to communities. There's a big push that proliferating bad data is actually harmful because it's not truly representative of those communities. And then I think this is the final one, high barriers to access, and I'll use a quick example here. One of our largest topics on the Health Equity Tracker is COVID-19 data. We use data from the CDC to present that. And the file that we get from the CDC is one, imagine a spreadsheet, and there's hundreds of thousands of rows on it. And each row is a case that is known to the CDC. When you think about that, who is the target audience for that file? It's not people in the community. Because there's a very high barrier to understanding that, that it's a very large file. It's not presented in a way that's, any kind of summary data. It's just a big file with cases on it. So when you think about the barrier, number one is understanding. Number two is the technical costs. There's a lot of investment needed from organizations to translate raw data into information that could be used by people at the community or at the point of care. So this is a quick slide to demonstrate a little bit. I didn't have enough time today to really dig into the tracker. It really is best understood by using it. So I would love to invite you all to go to healthequitytracker.org. I think there's a slide at the end with that information to really use it. But in terms of health equity lens to data, the one key philosophy is interactivity. All of our charts are designed to be interacted with. For example, this map, you could hover over the counties and it will dynamically show you the COVID rate for hospitalization, deaths, or cases. You could compare that county by county just by hovering your mouse over it. You could click into it to see the highest and lowest rates. So if you're looking again, COVID by county, you can see which counties are the best performers or the worst performers, and then you can make comparisons. So again, the gradient here, the dark green is really showing you very high concentration of COVID cases. The light green is relatively lower. And again, it's about being visual and interactive. We expect users to really kind of generate their own data. We picture the health equity checker as a tool in your toolbox, but it's not necessarily here's a screenshot. It's really a tool that you could use to try to drill down into your populations or areas of interest to really give you the data you need to support your initiatives. So again, the maps are designed to be easy to use. We think within 30 seconds to 1 minute, you could really get a key output from it, so you could get some particular insight on it. But if you have more time and you have, really want to layer into it, we make the data available for download. We show some charts, we show some tables, and really it's the same data in different views and different formats. And what we learned through our research was that really is engaging because people learn different ways. It's all about giving you enough information so you could understand at a surface level, this is representative data. But if you have time, you dig in further and you can engage with it and use it more often. So the map is one screen. We also have what we just introduced last week is time tracking. So those are line charts where you can see through the course of the pandemic. You could go back in time and see which communities were, vaccinated at different rates, cases counts at different rates, deaths and hospitalizations. So we plan to do that with all of our topics. For today, I know the topic's really about COVID and COVID vaccination confidence, but the health equity track is really designed to go beyond COVID and beyond vaccination. So we do comorbidity data such as diabetes, asthma. We do social and political determinants of health data. So there's incarceration data. There's women in legislative office, in terms of representation. There's data for that, poverty, insurance, and uninsurance. So where really vision for the tracker is to bring all of these topics, not just disease outcome and infectious disease or maybe chronic conditions, but really think about characteristics of the community, poverty, things like that, put them in the same platform as the health outcome data. And we think that could be really powerful to try to show correlation and kind of trends with that. So how does poverty influence COVID case count, for example, or how does uninsurance or preventable hospitalizations data impact the outcomes in the community? So again, it's a very broad concept. It's very exciting because when you think about health equity, it's very broad. The things that really influence our health, most of that does not happen within a doctor's office or a hospital. It's really conditions in our environment. So if you think about environmental issues, security, food insecurity, feeling safe and comfortable to go for walks around your neighborhood, do you have access to sidewalks, trees and green spaces in your community? Those things are documented to really have a larger impact in our health. And we think the data around that could be really powerful on a single platform. So I think I'll stop there. This is the website for it, and I would love to have you all feel free to go to the tracker and use it. There is a form on the tracker, and there's a contact menu. Really, I love to talk one-on-one with individuals. It's very important, as a product manager, I shouldn't be solving my problems. I should be listening to the community, people engage in the work and understand what are your problems and trying to boost vaccine confidence, for example, because I might have a lot of great ideas for the tracker, but ultimately I'm not the one that I'm solving for. So I spend a lot of my time every week talking to people, engaged in work, whether it's through policy work or community leadership. Tell me about the work that you have ongoing. And what I really want to do is understand what tools are you missing? What data, if you had it, would really give you a strong argument? or give you a strong presentation. So it's all about giving you the data and the tools. I invite you all to use the tracker, and I'm happy to take some questions.
Thank you so much for that presentation. At this time, if we can just give a virtual round of applause for all of our presenters. This has just been wonderful and a great time well spent. At this time, I will invite you to please continue to share questions in the chat box, and I'll begin to go through them. So I'm Dr. Catherine Y. Brown, honored to serve as your moderator for the Q&A. So one question that just came in states, may I clarify positions in both states? In Tennessee, you have health outreach workers before CHWs, as the training is not as extensive. Yet currently community health workers typically have other employment, but you want to change that to a full-time career. In Georgia, I only heard the term community health worker. Is that interchangeable? Community outreach worker, is that interchangeable with community health worker? Are these workers full-time? I want to understand the level of education training for each of these positions. Were there 3 levels to become a health worker or health outreach worker or community health worker? I am opening that question up to anyone who wants to answer it, because it can go so many different directions. So I see Dr. Matthews Juarez is coming on, Dr. Lozana is coming on. So let's give it to Dr. Lozana and Dr. Matthews Juarez. How about that?
So thank you for that. So just for clarity, so there are different approaches, so one thing about this particular initiative, we wanted to see what works, right, in Georgia and Tennessee. So, you may be familiar with community health workers. I have other grants that I work on at Morehouse School of Medicine that are COVID grants. We use strictly community health workers, or we use community health liaisons. One part of this particular initiative was about rapid deployment. So initially this was 9 months. So, we were trying to figure out a model, to get outreach workers rapidly deployed. So I would say it's both and. So you have people who may have had other positions, other jobs, students, who could work as outreach workers, and they didn't have to necessarily go through the longer community health worker training, which for us is 20 modules, is substantial, right? And so we had people who went through the outreach worker training, and then they can optionally take the community health worker training, because also, yes, we want to be a pipeline for people, for careers. So I think it's both and, both models, are great. We just tried to do different things because of the rapid deployment timeframe. And I think Dr. Matthews Juarez would probably like to add to that as well.
Yes, I will build upon that, Dr. Lozano. Each state has a different way of working, and we use 2 different approaches. And we read through the application. The overarching piece was, what do you do to get the community to begin to be vaccine ready, as opposed to hesitancy. And so we used the community health workers model because our state was used to that. The community outreach model is one that Georgia is. Relative to the pathways, this is a new model that the United States Department of Health and Human Services want to produce. And it's an exciting model. It's one that we've seen before, but with several different new add-ons. So we're excited about what we've done here in Tennessee and in Georgia, and we look forward to seeing how this all plays out. And everyone should stay tuned.
Awesome, thank you. So one more question for both. Is that training still available? They said Tennessee, but I'm going to ask for both states. Is that training still available?
Yes. And on the question, we use a certified model for training, both at the Baptist Training Science Center, which is focused on basic sciences and health professions. And we use the apprentice model that is deployed and certified by the Department of Labor out of the Office of Rural Health, the Rural Health Association of Tennessee. And so the training is defined. There's several courses within it. We've chose 4 to quickly deploy, but I'll turn it over to Dr. Lozano so that she can talk about what's happening in Tennessee. I mean, I was saying Texas, Tennessee, Georgia, and I'm not in any one of those 3 states right now.
All right, thank you,
All
Dr.
righty.
Matthews-Juarez. So yes, the training is still available. So like I said, we have different training. So we spoke about the outreach worker training, which is a short course. We do have a longer community health worker training. Morehouse School of Medicine, again, just like Meharry, we've been training community health workers for over 20 years. It's been a long time, right? So we have different levels and different types of training. In addition, we have several adaptations, cultural adaptations. We have a Native American adaptation, Alaskan Native adaptation, a Haitian American adaptation. We also have an opioid reduction adaptation that we've done. So we have the high school and young adult community health worker training. So again, it's really looking at different models, for different audiences. So, we'll continue.
I love it. Okay, so I want to pivot again because all these experts on here, I'm getting excited. Now, a couple of things. All right, so I don't see any other questions except for I have one about, is there an health equity tracker available in the state of Tennessee?
We used, yes. Paul, go ahead. Someone was going to answer.
Sorry, this is Juan Carlos. So by state, it depends on the source of our data. So for COVID vaccine, we do have data available by state. A lot of our sources go down to the county level. So if you go to the tracker, and I'll put a link in the chat, you click on it and you can see a national map. And if the color is grayed, that means there's no data available from any of the sources we use. But if there's a color on that, you could click into it and see what the data is.
Thank you.
I was just going to add that there are several ways in which data is being tracked. And each organization and each school may use a very different way of looking at it. We are in the process of working with our Data Science Center, the Center of Health Disparity Research, and we track all data, as does the state of Tennessee. You can go on right now and look at whatever is happening in each of the 95 counties. 89 of them are tracking data. And so it's not unique. Any academic science center now worth its salt is now tracking data having to do with health equity. And health equity is not a big term. It has to do with access. It has to do with geographic distribution and utilization, care coordination, and overall, does the patient, the person, get what they need at the time that they need it in order to stay well? So that's really what health equity is. And so we make it seem so sexy and so difficult, but it's really about access. It's about getting the resources that you need. So yes, there are trackers. And now with the COVID Health Disparity Grant, in which we have a large segment of that, we track COVID-19 and all other chronic diseases having to do with the social determinants of health. Thank you.
Okay, great. So, all right, here we go. So Juan Carlos, I'm giving you a heads up that I'm getting ready to come back to you because Dr. Lozano wanted you to add some additional information. But before I do that, I'm gonna give you a moment to think about her question that's in the chat because it's coming to you. But I do want to share a little additional information from HealthWorks at Meharry. One of the things that I wanted to note that they've served 89 counties out of the 95 counties, recruited and trained 102 community health workers, and completed over 6,700 boosters and vaccines in 8 months, even with a late start. They've held over 250 events and held over 60 planning meetings with 32 community partners, including vaccine partners. They also want to note that they have served over 150 churches, more than 30 businesses, along with the Black and Hispanic Chambers of Commerce. There are 3 shows: Follow the Science with Dr. Paul Juarez, Wellness Wednesday, and Wellness Today with me, and Wisdom Corner with Reverend Neely Williams. We have over 5,000 followers on social media, and we've even gone so far as to wrap an ice cream truck. So there you have it. Now, Juan Carlos, you got a lot of time here. I want you to talk about how you train the health outreach workers to use that tracker and their reactions to the training. After you share that, I'm going to toss it back because we got 10 minutes. You can't take 10 minutes. You get about 1.5. Then I want to see if Dr. Matthews Juarez or Dr. Lozano want to share anything else if there are no other questions. All right, Juan Carlos, my friend, there you go.
Thank you for the heads up. That's always appreciated.
I know.
So, so we spend, a lot of our time, it's about education and training, and we met with the outreach workers to do kind of a demo, but also kind of a feedback session. So what we show is really try to use the tracker in a way that's natural to you. And we try not to lead more than that. I try not to do a training where I explain everything. I try to introduce it. And that's what we did. So we did a screen share with a lot of the outreach workers that were present. The feedback's good. I think there's a lot of desire for data to really kind of, in your conversations with people in the community, have facts that you could go to and definitions that you could go to. So a lot of the conversation was around that. We ended up developing an infographic, with frequently asked questions on the tracker. And I think you're waving me to stop talking. I'm not sure, but I'll stop there. But the idea.
No, you're good. You're good. All right. So this is good stuff. Now, here's what I want people to take away is that health works because health works, right? So we've done a lot of work. We've listened to the voices. We've had lived experience. We've had data, statistics, and we know that we made an impact. So in summary, we're going to go back to the larger group and debrief about what we learned, and we've learned a lot. So in the chat, if you want to share with me what your major takeaway was from this session, and if any of our speakers would like to unmute and just answer one simple question, where do we go from here? All right, so in the chat, I see a lot of you. Please share if you have a great takeaway. And it looks like Dr. Lozano has unmuted.
Yeah, I just want to say one thing just about data. And so what we're working on really is for community health workers, for outreach workers, really having specific data that they can use to really kind of understand, where they need to do outreach. This is crucial. So one thing that we're seeing is that we're seeing more and more the embracing of community health workers, right? So with the different grants that are coming, we're getting a lot of them. So one thing that we need to be able to see is where are the other, community health workers doing outreach, right? So can we pair together? Can we partner? Are there some gaps? So we need to be able to see those things. So one, it's producing data that community health workers or outreach workers can utilize. A lot of times our data dashboards are too complicated, right? So we need something that they can utilize to figure out where they need to do outreach, and also be able to give them feedback on the data that they're collecting. So that's important. So a lot of our community health workers, outreach workers are inputting data, they're giving us information about what they're seeing, out in the field. So we should be able to give that data back to them, as well. So I just wanted to kind of expound on that. And so that's why the health equity tracker, in that instance, it came in handy because as Juan Carlos did the demonstration to show them how to use it, they were really excited. That was one of their favorite, learning sessions. And then how they can, be able to understand and utilize data for their outreach. So, again, just kind of bringing that, that's my takeaway, I guess, or lessons learned, or things that we need to augment. Thank you.
I love it. I love it. All right. So I am going to you, Dr. Matthews Juarez.
Well, we are twins today, tied at the hip, Dr. Lozano and I.
That's my best friend.
That's right. The exciting news is that data drives everything. You can't make the right decision unless you have the right data, right, Dr. Lozano? And so the more information that we're able to give community health workers and community outreach workers, or whatever the nomenclature is that we're using, the better our community is going to be, the healthier our community is going to be. And at the end of the day, how do we measure how well we've done with derailing the misinformation? We'll talk about how lower the rates are in our community for COVID-19 and what we are doing to protect ourselves, so that when we talk about long haulers, that we're talking about the idea of these priority populations that what Carlos is talking about, and we're trying to put it into context for, is this population well educated about what it is that they have to do for themselves, their children, and their family? Is this population able to make a decision and ask the right question when they go and see their provider, their primary provider? Are we doing what we need to do, not just for COVID-19, but for all of the chronic diseases and the social determinants of health? Because Dr. Lozano said, you know, when COVID came, we began not only to see the diseases, but all the other situations that causes individuals not to do well and live well and be healthy. So as I close, I think that, you know, this new idea of giving information to community health workers, we're going to see a really big plus in our community and in our federally qualified health centers and in our private clinics as well. So I'm all for working really hard at getting that done. That is just absolutely wonderful.
I love it. I'm going to jump to the chat. It says, this is a great discussion. Any questions that I wanted to ask were asked and answered. My key takeaway is that the data tracker and how community health workers can use them to develop an outreach strategy. Another comment, thank you all so much for your time today. I work on a vaccine hesitancy grant in Oklahoma and am also part of a CHW coalition. It's always amazing to learn from diverse models. We all want the same thing, a healthy community. Excellent. I also see Dr. McCrae's hand, so I'm going to go back to you.
I just wanted to say that, you know, community health workers can use those trackers if they are sustained as a workforce. And that's not what we have now. We don't have that sustainability. In the next 3 to 5 years, all these different grants that are hiring community health workers will be done. And so have we made the case that we need CHWs in communities at all times to increase health literacy, to be woven into that fabric of health care, so that the social determinants are observed and barriers are removed to care. That's what a CHW does. And so we need to work during this time that we have the CHWs and the funds to figuring out how we fully integrate CHWs into the healthcare workforce. Thank you.
Excellent. Thank you. And someone already said in the chat, great point. I'm going to keep good track of time. We have 2 minutes left. And some of the takeaways that I hear you all saying is that we have to look at, are we doing what we need to do to address the chronic diseases and everything that was revealed during COVID? I think that's what I'm hearing you say. And that the message must be relevant to the community and be in terms that they can understand. I also hear you telling me, trust the science and follow the data. Build confidence and trust, because trust saves lives. Another thing that I hear you saying loud and clear is that clear, consistent communication is key and consistency matters. Is there any other 30-second takeaway that you want me to share with the larger group before we end this time together? Anything else? 30 seconds in the chat. I'm watching the chat. Got 10
I would
seconds.
like a quick comment.
Okay.
So I think, again, about the data, our chief of staff says it should be robust enough to be fully featured, but simple enough that his grandma could use it. And that really is a philosophy. The data, if it's too complex of a platform, then people can't use it. We really need to leverage that usability.
I love it. So make it simple enough that grandma can use it. And on that note, I thank you, all of our speakers. Again, let's give a round of applause for all of our speakers. You were absolutely amazing. We appreciate you all, thought leaders, content experts, and community stakeholders. At this time, this session is adjourned, and we're going to go back to the large group discussion. Have a great day, everyone.